Welcome. I'm Louise Hansford, and I'm a registered public health practitioner, and I was also blessed to receive the Alison Thorpe Translating Evidence into Practice Award for a project that I ran a couple of years ago last year. So I'm just going to talk to you a bit about Hep C elimination and why it's so important and why the time is now to do that. So as I said, my name's Louise Hansford, and I currently work for the NHS Addictions Provider Alliance. So we are currently now a collection of NHS trusts that work across the UK, and we have 17 different members. So our furthest north member is in Newcastle, and our furthest south member is in rural Dorset, and we've got representation up and down the country. Just to give you a brief history, so the addictions sector have been ravaged with cuts, as have a lot of other sectors. So they really wanted to come together to be able to kind of advocate for policy, to advocate for funding, to just really share best practice. And as my slides say, to really create a clinical network structure to come together. So as part of the NHS Addictions Provider Alliance in 2020, Hep C Elimination was formed. So we're going to talk a little bit about the wider strategy and policy and guidelines that we work within. But basically, in 2018, new direct-acting antivirals came onto the market. So the treatment previously for hepatitis C was interferon and ribavirin, which are interferons used for chemotherapy. Didn't have high success rates with horrendous side effects. So a lot of our service users were unable to access that treatment, let alone complete the treatment. So in around 2019, NHS England went into a strategic procurement with 3 big drug companies that had new direct-acting antivirals. They are Gilead, MSD and AbbVie. And as part of their tender for a market share of the treatment run, those pharmaceutical companies had to show how they would reinvest their profits. So Gilead Pharmaceuticals went into partnership with a lot of the drug treatment sector to provide Hep C coordinators, data analysts, and a real kind of workforce dedicated to doing this. So they went into partnership with the NHS Addictions Provider Alliance, and our Hep C Elimination project was formed. So this slide just gives you a bit of brief detail. We're a very small team of 8 people. I work in the south, and then randomly I coordinate Newcastle. So my role, I work across 6 large NHS trusts. I've got about 50 services in my portfolio, and I really work with them to do innovation projects, to look at their data, to look at their records, to bring people together. So it's an incredible project. And actually this morning we were looking at why did we become registered and what's happened since. Absolutely, I'm on secondment at the moment, and it's a higher banding than my substantive role. I do believe if it hadn't been for my practitioner's portfolio, my registration, and me undertaking a master's, I wouldn't have been able to secure that job. So one of the big things about Hep C Elimination is our social media campaign. Hepatitis C as a bloodborne virus is prone to being stigmatized. People are generally marginalized, disadvantaged. You may have seen the contaminated blood scandal. So that has changed the landscape a bit, and it has suggested that hepatitis C, you don't have to be an active injecting drug user, which unfortunately sometimes are seen as the lowest in society, very wrongly actually. So part of our Hep C Elimination project is really spreading those messages and kind of trying to tackle that stigma and discrimination. So the Hep C elimination strategy, as I said, it's underpinned by NHS England. It's also underpinned by the World Health Organization guidelines and commitment to eliminate hepatitis C as a global public health threat by 2030. Nationally, NHS England want to do it by 2025, and of course the Addictions Provider Alliance want to do it by the end of next year. And I've got to say, we are on track in an awful lot of our services. So collaboration, shared learning, our drive to deliver excellent care to service users, and you can be the most important part of the puzzle, you know, and anywhere that there's discussions. And what I would say is that the one good thing that I can think of that's come out of COVID is people have an understanding of antigen and antibody test and RNA and PCR tests. So actually, you know, I'm not scientifically trained, but there are a lot of similarities with the R numbers, how obviously it's blood to blood for hepatitis C, but there are similarities with how quickly hepatitis can get onwardly transmitted through, particularly for injecting drug users. So in the New Forest, which is one of my services, I can trace one hepatitis C infection to 17 other people, and that's just through doing networking links. So I've got a poll question for anybody. So I don't know how I do this. Let me just see. Okay, so the poll, how many people do we think are living with hepatitis C in England? If you could please vote. So the options are less than 25%, 25,000, sorry, 25,000 to 50,000, or greater than 50,000. If you could please vote now. You go into the little poll function, which has got 3 blue lines on your right hand of your screen. You can tell so my participating in this conference today, I've learned something new, which is how to do a poll. So very interestingly, there has been obviously a bit of difference. So we're going to come on to this now. So the answer is 81,000, and that comes from the Hepatitis C in England report, which is run by UK Health Security Agency, underpinned by data from the Office for Health Inequalities and Disparities. So what I would say is the project that I'm going to talk about in a minute, which is the one I won the award for, was very much based when there wasn't a lot of resources for hepatitis C. And we have actually, when I first started out working in Hep C 10 years ago, the number living with Hep C in the UK was, they estimated at 300,000. So that will just give you a numerical kind of vision, really, of how far we have come. However, there are still there's still a few big milestones that we've got to get to. So there's 26% prevalence in people who inject drugs, and addiction services prevalence is currently sitting at 10%. And again, just to give you a bit of background, when I first started in Hep C, the estimates were 85% of intravenous drug users were infected with hepatitis C. And over the years, it's given me great pleasure to see that number actually decrease. At the moment, across the whole of the UK, we are testing 11,000 people over a 6-week period using capillary bloods. And that will give us a real sense of the incidence and prevalence now, because as you can appreciate, there are people with risk factors that we're not getting to. There's the people that would have had contaminated blood from years ago that don't even realise. So this will try and give us an accurate representation of what we've got left to do. The DAAs cure most Hep C infections if taken as prescribed, and that is the subject of my MSc dissertation. I'm doing a piece of work on the people that are prescribed DAAs that aren't able to take it as prescribed and subsequently don't clear the virus, and what happens to those. Because this is the biggest thing, is that for this group that, as I said, that are often marginalised, sometimes they cannot want to come back to tell the people that they haven't been able to take the tablets. you know, and that shame and that self-loathing, that stigma can really keep people out of services. And if you think back to earlier where I said 1 infection to 17 people, if at the end of this we leave people untreated, then frankly all the resources that have gone into it for the last few years could be in vain. So we need to make what we've done sustainable, which is where, as a public health practitioner workforce, you know, I would just urge us to consider it, to still have those conversations. For those of us that work in commissioning, it's essential that Hep C doesn't drop off the commissioning radar. So the Basel guidelines, so the British Association Study of the Liver, they now say, and I was going to be cheeky and do another poll, but that everybody should be offered treatment. So if any of you have read my bio, I'm in recovery from drug addiction. I'm nearly 20 years drug free. I was an intravenous drug user. I ended up with hepatitis C. At the time, I had hepatitis C in 2003. Well, I was diagnosed 2001. But at that point, I had to be 2 years drug free to even be offered Hep C treatment. You know, and for years, up until the last couple of years, we've gone, no, you can't have treatment, you're using drugs. No, you can't, you're drinking. No, you can't, you're homeless. No, you can't, you're about to go to prison. No, 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 no. And now we're going, have some drugs. And there's a cohort of people that we have to be really careful we don't add to health inequalities and disadvantages. Because if we don't do that holistic care and support somebody to be able to get through treatment, then it's going to just have a detrimental effect. So for me, conversely, the new guidelines that we're working under, where everybody can have treatment, we've kind of lost that space where we would build relationships. And I think for me, we've definitely got to get better at building those relationships and giving people the optimum chance of succeeding. So yeah, the minimum workup for those that aren't engaged in care, that's where those people can end up sadly getting lost to follow up, and it's a constant battle. But the rewards, you'll see in a minute, the rewards when somebody actually accepts the Hep C treatment, goes through it and comes out the other side, are just phenomenal. You cannot underestimate the impact that course of treatment can have on an individual's life, but also the lives of those around them, their family, their friends and their community. It's incredible. So micro elimination is a service by service approach to achieving Hep C, and this is a quote from a researcher that I've got to know. So he basically says it encourages stakeholders who are most knowledgeable about specific populations to engage with each other. So and again, I'll make reference to this in my Andover project. The Andover project was absolutely phenomenal because we had community mental health, we had pharmacists, we had drug workers, we had honestly, everybody got involved in this project. And from being an area with multiple deprivation and horrendous health inequalities, to achieve what they did was, I mean, it will always be one of the highlights of my career. So this is possible by effective partnerships, well-trained workforce, and for those of you that heard me speak earlier, you know, Dame Carol Black did a review of drug treatment, and she found that we had a lot of staff that hadn't got a career pathway mapped out. They hadn't got qualifications, and I will always sell the value of the public health practitioner registration, because it gives you so much more, and it gives you a whole network of people to communicate with. High quality data builds and maintains trust and credibility. And for me, one of my biggest frustrations in this country is that we have a drug treatment record, you have a GP record, you have a hospital record. If you split over, for instance, I use Andover, you may have a hospital record in Basingstoke, you may have one in Southampton, and you'll also have one in Andover. And you would think that it was really easy that those systems would communicate with each other. They don't. So one of my biggest passions is about that record completeness and about kind of accuracy, because I think it's really important that when we're dealing with patients and their data and their information, it needs to be right. So Andover accessing the inaccessible Hep C Elimination project, and as I said, I was privileged to win the Alison Thorpe Translating Evidence into Practice Award last year. So just to set the scene, as I've said, so Andover, a rural community, very poor transport links, and when you look at the social determinants of health, you know, they're appalling for there. There's low education, there's the transport, there's just not very good job market around there. You know, we had a high level at the start when we secured the funding. We had at least 25 patients with known Hep C that had Hep C for some of them for 20 odd years and were getting poorly. And they had myths about testing. There was stigma. There was a lack of willingness because at the time we needed to get venous bloods, and for somebody that's used drugs intravenously, the venous access is a real barrier, and it can be really traumatic. And as somebody that's been phlebotomy trained, I had my anniversary yesterday for 6 years. You know, I will never disrespect a service user that tells me that you're not going to get my blood. You know, it is immoral and unethical for somebody to walk out of phlebotomy with 7 or 8 plasters on them, and I've got personal experience of that. So I know what it's like being on the end of a phlebotomist that sees you as a challenge and absolutely is determined to get your bloods. So prior to the project, only 1 patient had been treated. And just to put that in a bit of context, so I'll call her Mavis, as I often use the examples, Fred and Mavis. Mavis had been referred to Andover Hospital, and Andover Hospital delayed in sending her to Southampton Hospital for treatment. And Mavis also was under the rheumatoid arthritis team, and she ended up seeing a letter that had been written from the liver consultant to her arthritis consultant. And let me tell you, I have never seen such a judgmental, discriminatory letter in all my career. It was horrendous. And you know, like many on this call today, I'm triggered by injustice, you know, unfairness, unjust. And this letter talked about how she didn't deserve treatment. She was using drugs. She wouldn't comply. I mean, it was horrific. And in the time that consultant delayed because of his judgment, from her going from him over to Southampton, her liver disease tipped over into fibrosis, into cirrhosis. It's not acceptable. You know, for that lady taking her over to Southampton Hospital, she was entitled to £8.62 in benefit. She had school children. You know, we worked really hard to get her appointments at Southampton Hospital so that she could drop her children off at 9 o'clock and be back for 2:30 to pick them up. It was a challenge. So we secured funding, and it formally started in July 2017. We did targeted testing just to do a bit of a stock take. So as you can see from the slide, 158 people were tested out of a possible 161. We utilised the BBV champion and peer support. So we had somebody that was employed who had lived experience to come alongside people. There was a robust approach. The most stable patients were started on treatment. And I normally talk about Fred and Mavis at this point, but I'll have to call her Cynthia. So we had a couple, Cynthia and Fred. So Cynthia was doing really well. She was drug free. She was quite influential in the peer group. She was doing a lot of art in the hub. So we got her along to as somebody that could then spread the message. Her partner, Fred, they've been in a relationship for many years, was like, well, when Cynthia does it and Cynthia doesn't have side effects and Cynthia clears it, I'm going to do it. And this went on for quite a long time. So the first cohort was Cynthia was in there. You know, it was just, you know, it was honestly, I look back at the photos now with fondness, because there's something about challenging stigma and discrimination. You know, we held a clinic, and the clinic started at 9 o'clock on a Monday. and everybody attended. And I think the reason they attended is that unconditional positive regard. They weren't stigmatized, they weren't discriminated against, and there was a community feel, and we made it okay to have Hep C. And that was perhaps for the first time in their life that anybody was able to be open and honest about it. So all this was going on, and Fred was still not coming forward for treatment. And I went back to him, and he would be like, "No, Louise, I've got some other health stuff going on. No, Louise, it's not a priority. No, Louise, no, Louise." And this went on for about 2 years. And what happened was that in the end, he asked our consultant to tell me to back off. So I sent him one letter and saying, "Look, I know it's not a priority for you now, but literally we are getting down to the last couple to treat. And if you don't come forward now, you're going to have to go back to Southampton." So yeah, and then I went to a conference in Canada and presented the work in SHU, which is coming up in a few weeks. And you can see on the first slide, the one that's got 154 next to it, you can see the poster. And what you might be able to see here is it says "One left to engage." And I was leaving the Montreal airport, and I had this poster in a tube, and the original check-in person said that I'd have to pay excess luggage. So I was thought, well, I'm not going to pay 70 quid to bring a poster back that only costs 45 to print. So I was looking for somewhere to dispose of it, and another airport official waved me through. So I bought it back, and I took it to the Andover service and put it on the wall. And Fred came in, and he was talking to Amy, our receptionist, and he went, "Is that one me?" And she's gone, "Yeah, Fred, that's you." "You've broken my confidentiality." She said, "Fred, it doesn't say your name." He said, "Right, that's it, put me in." So he was booked in to see myself and Sarah, his recovery worker, and we were like, right, here we go. We walked in expecting another kind of whole session of making every contact count and motivational interviewing. And he went, "Right, put me in." So we booked him in for the nurses. On the day he started his treatment, I went in and I said, "Fred, do we need to talk about some graffiti?" Because as you can see from the second poster, what Fred had done is scribble out the "One left to treat." And the reason I share this is it makes me smile. It you know, on a stressful day, I look at this and I go, yeah, because everybody has got a role to play in it. Anybody can start those conversations about health. Anybody can start those conversations about inequalities and what we can do to support people. So yeah, Andover are probably one of the only services in this country that have tested everybody and have maintained their micro-elimination status. They have no Hep C in their current service users. You know, they were the worst team in Hampshire. They were so resistant. It was like, no, we're not doing it. It's a nurse-led task to test. And to go from the very worst to, it's like I say, it was all underpinned by policies, by procedures, you know, the UAM survey, you know, everything that I have learned as a public health practitioner, I have used in this. And you know, this writing about this was my first commentary. And actually, I was able to hit, I think 30 odd standards, you know, absolutely phenomenal. And these are the real people, the real lives, real impact. And Dean, who's the one in the grey hoodie at the end, he was resistant to treatment because he thought he was going to come out in pink spots and grow an extra testicle. I don't know who was more disappointed, me or him, that didn't transpire. But yeah, so that's me. So I will stop sharing my presentation now. I hope you found that useful, and we've got some time for questions and answers now. Oh, lovely.
Hi, thanks, Louise, for sharing and just telling us the real story and how it is on ground. And yeah, I think my question is mainly a general one. Is there anything you would advise to do differently if anyone was going to start to do a similar project?
Great question, Monica. Thank you. I think Andover was a dream. We originally, it was quite difficult to get the buy-in, which feels and grads, sorry if I pronounced your name wrong. So originally it was very much, there were people that weren't interested, and then when we got the funding and we were ready to go, people got on board. And I'm very passionate and committed, and there are also on my practitioner's portfolio, when I did the insights profiling for as part of the Wessex scheme, there was a whole section on how to working with people that are different for you. And I think for me, sometimes my passion and my enthusiasm, if people are very different to that and are introvert and green and yellow instead of green and blue instead of red and yellow, they can go, who is this woman? And so I guess I think there may have been something about getting to know the wider stakeholders. One size doesn't fit all, I think, for stakeholder engagement and getting people on board. The other thing was the data and sharing. That is always tricky because the systems don't talk to each other. So so just to the other question, the team, so literally we had pretty much 100% attendance at the clinics, and the reason why we did that, how we did that, is the pharmacies would get involved. So we would send an appointment letter to the pharmacists, and they would hand them to people when they came in for opiate prescribing or they saw them. The local soup kitchen would remind people that the clinic was on. It just became that real community feel, that it was a project that we were really going to do together, and literally everybody got involved. I wish I could replicate it across the country, and I don't know what made it work so perfectly, but it did, and it continues to work.
Yeah, thank you very much. Very inspiring.
Yeah, and originally the hepatology nurses from Southampton, originally they said that there wasn't the need in Andover. There wasn't that it wasn't viable for them to come out and run the clinic. So we just collated that evidence. So in the original funding bid, I showed how many people had been referred to Basingstoke Hospital, the high levels of DNA for different people. That motivator. For some people, it can be the inequalities, the unfairness. For other people, it can be the financial hit. For other people, it can be the do not attend appointments and the time that goes into it. And I think we were able to pull in everybody with a different objective. So yeah, thank you. So I think Angard, I hope I've answered that question, but it was just, I think it snowballed. I think originally there might have been a bit of resistance, but when stuck people, so when Cheryl, did I call her Cheryl? When Cheryl went out into the community and talked about this Hep C treatment that she was on and how well it was going, and the fact that she was starting to feel better, it spread. I think that stuff's really contagious. So I think even the resistant people got on board with it. I mean, what I would say in your professional lives and even in your personal lives, like hepatitis C is out there, but we've got a chance to be part of an elimination of a virus. Never before has this happened without a vaccine. So, I mean, this obviously with COVID as well, but this Hep C elimination will be the stuff of the history books in years to come, and I feel very privileged to have found myself like working within it. And I look forward to the day when I can tell my great great might be a bit of a push, but my grandchildren that I was part of something. How many of us can actually sit back and go, yeah, we've made a difference, and yeah. Joanne, Joe, I don't know if it's Joanne or Johan or I'm probably pronouncing it really wrong. I'm very apologetic. So the elimination tender at the moment, there's some micro elimination in prisons. I think I haven't got the statistics, I've been making it up, but there is a high proportion of prisons now that have done micro elimination, and how they've done it is through high intensity test and treat. So a team will go in there. If you have a look on the Hep C Trust's website, they've got quite a lot of write-ups about it. So a team will go in. So they've recently done Eastwood Park, they've done Bronzefield, they've done quite a few men's prisons, they've been into Bristol, and they literally test everybody. And locally to me in Wessex, the OGN clinical lead, they topped up people's canteen and gave out chocolate and things, and just incentivized people testing. And again, people in prison can feel very judged or dirty for having Hep C, but again, we just changed that trajectory. So there's phenomenal work going on in prisons, and ironically, for some of our guys that we've struggled to get them engaged in the community into treatment, when they go into custody, by us acting really quickly and through that network, we're able to flag that Fred's gone into custody, and the prison team have been really responsive. It's never before have I known so many organisations, so many drug services coming together with a single purpose. You know, it blows my mind really how for years, like when I set up a Hep C project in 2012, it was commercially sensitive. I wasn't allowed to talk to anybody about what I was doing. And those walls have just come down. You know, just before the conference, I was talking to a colleague in a big drug service. You know, we're able to have those conversations, and I think it's really set the scene for how we can do things, that instead of being precious about what's going on in our areas, the more open and transparent we can be, it's only going to be good for our population. My details are freely available, so if you did have any questions or wanted to be linked into people in your own area, please do feel free to reach out. But I think the session is probably just coming to an end anyway. So thank you ever so much for joining, and I hope you found it useful.